I heard there was some consternation about whether what I was going to say was going to conflict too strongly with what Nick was going to say subsequently. So I'm going to take the next 40 or 45 minutes to go through my presentation so that Nick doesn't have a chance to respond. But seriously, I hope to be a little bit controversial and perhaps say some things that are surprising compared to where you think I might be coming from. These are my disclosures. So let me just give a brief introduction about the problem of drug resistance. And as I think most in the audience know, the emergence of drug resistance is a particular problem for RNA viruses, including retroviruses. And that's because for all RNA viruses, the populations comprise a quasi-species of very closely related viruses, none of which are precisely identical. And these variants arise from an original oligoclonal inoculum, and it's the error-prone nature of the RNA-dependent polymerase, in the case of HIV, the reverse transcriptase, that generates all these mutations that causes resistance to be such a problem. And if we think about this quantitatively for a minute, the viral genome contains about 10,000 nucleotides, and the mutation rate is roughly 1 in 10,000, which means that if there are 10 to the 10th virions produced every day as the product of somewhere between 10 and 100 million rounds of replication, every single possible mutation is made on a daily basis in patients prior to initiation of treatment. And so all of the resistance mutations may be pre-existing, at least as individual mutations, but much less likely to be present as combinations of mutations on the same genome, which is why combination therapy has really become the hallmark of effective therapeutics for HIV infection. So from the perspective of the US, Europe, and Australia, in the bad old days, the era of mono and dual therapy, failure to achieve full suppression of viral replication invariably led to the accumulation of drug resistance mutations. And accumulations of these mutations led to increasing within-class cross-resistance. The more AZT resistance you had, the more resistant you were to didanosine and to stavudine and to abacavir and even to tenofovir. And this problem was compounded by the addition of single active agents as new drugs were developed, equating to serial monotherapy. When patients had failed on AZT and 3TC and we added indinavir or nelfinavir as a single new protease inhibitor, we failed to achieve suppression and promptly selected for PI resistance, and then moved on to lopinavir and added more mutations. And this, of course, created an opportunity for the transmission of drug-resistant virus, including multi-drug-resistant HIV, that exacerbated the problem. This is an old slide from Andrew Phillips showing the risk of developing drug resistance in their clinic in London, the UK Sheik study that looked at over 4,000 patients longitudinally from 6 different clinics. And you can see that over time there was considerable risk of accumulation of resistance to at least 2 classes of drugs. Most commonly, this was to one nucleoside, typically 3TC, and one of the NNRTIs, or a couple of the NNRTIs, usually nevirapine and efavirenz. But resistance to 3 classes was less common. The overall risk of treatment failure was about 40% after 6 years, and the risk of accumulating resistance mutations to any drug was about 25%. This led to substantial transmission of drug resistance, and here you see now again older data from the US Centers for Disease Control looking at the detection of drug resistance in newly diagnosed individuals, some of whom had recent infection, many of whom had been infected for some time but were just becoming aware of their HIV status. And you can see that in the period from 2007 to 2010, 16% of newly diagnosed individuals had evidence of resistance to at least one drug. Most of this was resistance to the NNRTIs, 8%, and only 2% had multi-class resistance. A slightly more recent update, and the CDC data really lag the time periods, and these are based on sentinel surveys done in the cities shown here on this map. But you can see that, again, by 2011, somewhere between 17 and 18% of newly diagnosed individuals had any evidence of transmitted drug resistance, and that was mostly NNRTI resistance, about 10%, but PI resistance remained relatively less common, and integrase resistance is not at all shown on the slide because it wasn't tested for. Transmitted drug resistance in the context of efavirenz-based therapy had significant consequences. These are data that we developed from an AIDS clinical trials group study conducted in the era before we were doing pre-therapy drug resistance testing, and went back retrospectively and tested the baseline samples. And you can see that among those who had evidence of a transmitted NNRTI resistance mutation, they were substantially more likely to experience treatment failure in the course of the study compared to those who did not have treatment NNRTI resistance. This was true even if we looked at the presence of minority variants by using more sensitive techniques. And actually, this analysis is a pooled analysis of 10 different studies where John Lee and my group was able to go back and get the primary data, patient-level data, and do a pooled analysis of the patients from all of those trials, which used different techniques for detecting minority variants, and showed that if you could find evidence of resistance, that these participants were about 2.5 times more likely to experience treatment failure than if such resistance was not present. And in a further analysis, if you looked quantitatively at the number of copies of mutant virus in plasma, there was a highly significant trend that having 1 to 10 copies of mutant per mil versus 1,000 copies, you had an increasing risk of resistance going from just under 2-fold to more than 4-fold. But resistance accumulation has slowed over the years as our therapies have become more effective. And they're more effective because they are more potent, they're better tolerated, they're more convenient, a whole variety of reasons. And as the efficacy of treatment has improved, and as the incidence of treatment failure has diminished, so has the incidence of accumulating drug resistance. And here you see in this follow-up paper, again from Andrew Phillips and the Sheik cohort, that looking now over a decade, it took at least 10 years to get to the point where 10% of patients in their cohort had evidence of multi-class drug resistance, and there were relatively few of those participants, only 6 at that time point. That is validated by additional data from Gilead looking at the prevalence of resistance in participants screening for entry into several phase 3 trials. And you can see the 903 study, which was a study of tenofovir in first-line therapy done in 2000. There was about 0.5% resistance for NNRTIs, whereas more recently there was a much higher prevalence of NNRTI resistance. But the prevalence of nucleoside resistance has actually declined slightly. The prevalence of PI resistance has more or less doubled but remained relatively uncommon, and the presence of integrase inhibitor resistance has also remained at a very low level. Further data show that again, over time, the incidence of, or the prevalence, I should say, of triple-class resistance is diminishing, and most resistance has been centered around the non-nucleoside RT inhibitors. These data from Switzerland, I'll take a little bit of time to go through because it's a somewhat complicated slide. Here, what you see is the number of individuals who are on antiretroviral therapy, and then you see in the red those who ever had drug resistance detected, and then in gray those who had triple-class resistance. And what you are seeing, this is by year, but for the group who were treated before who started antiretroviral therapy before 1999, there was relatively frequent evidence of resistance shown here and of triple class resistance. Those who started between 1999 and 2006 also showed increasing resistance. But those who started after 2007, you see very low rates of resistance, even though the numbers of people who started in that era are comparable to those who started in the previous era. So if we look at the prevalence of resistance at the time of treatment failure in some of the more recent studies, you see that these are much less common than we had seen in the days when we were doing studies with NNRTI-based regimens. And this is a modification of a table presented at CROI this past February, looking across a number of different studies that used boosted darunavir. And you can see that there were, out of nearly 1,700 participants, only 4 had evidence of protease inhibitor resistance at treatment failure. Only 10 had evidence of resistance to a nucleoside, most commonly 3TC or FTC. Actually, in these studies that used etravirine, only 2 people had evidence of an NNRTI resistance when it was combined with boosted darunavir. In our own study that compared boosted atazanavir and boosted darunavir to raltegravir, led by Jeff Lennox and published a couple of years ago, there were, back up here. There were, out of 1,800 participants, only 300 virologic failures, and we were able to genotype 94, 85, and 115 of these, and you can see that, again, resistance was quite uncommon, mostly to the nucleosides, rarely to the, if ever, to the protease inhibitor, and then occasionally to the integrase inhibitor. Similar results were obtained by Paul Sachs in the studies of Dolutegravir as a fixed-dose combination, and you see that out of 350 participants in the 2 groups, only 4 or 5% had virologic failure at a level where you could do resistance testing. Only 2% of the population developed resistance, and that was, again 3TC or FTC resistance was the most common nucleoside resistance, and then a handful of integrase inhibitor mutations in the Dolutegravir arm, comparable to the low rate of efavirenz resistance, again, because with fixed-dose combination therapy, treatment had become more convenient and more effective. These are data from Kristen White from Gilead looking at the Dolutegravir resistance compared to boosted atazanavir, and again, with the boosted PIs, no evidence of resistance, and with Dolutegravir, infrequent resistance at the time of treatment failure. And of course, with Dolutegravir in the single study showing that there was no evidence of emergent resistance to the integrase strand transfer inhibitor, no resistance to the nucleosides compared to the emergence of some nucleoside and NNRTI resistance in the comparator arm. Well, so with these more effective regimens, the question then becomes, does transmitted resistance still matter? If we're no longer using NNRTIs, if we're not focusing on NNRTI resistance, but on transmitted nucleoside resistance, does that resistance really undermine the activity of these regimens? In our own study, the minority variant study, we could not demonstrate that having resistance to thymidine analogs or to 3TC or FTC had any impact as opposed to the impact of NNRTI transmitted resistance. And Anna Maria Giretti saw exactly the same thing, and looking back in their cohort, you can see here the The blue solid line is no resistance, and then the dotted line is presence of TAMs in patients who received an NNRTI-based regimen, and there's essentially no difference in treatment outcome. The outcome on the non-nuke regimens was slightly better than in the PI-based regimens. This is not a randomized comparison, but again, even with the PIs, it didn't matter if you had transmitted nucleoside resistance. And in a paper that just came out in the Journal of Infectious Disease, Margot and colleagues from Gilead, looking back at their accumulated experience, found that if you had evidence of transmitted resistance, so resistance at the time of entry into studies that used either tenofovir or TAF, there was no difference in outcome. And you have to read the graph line by line here, the chart line by line. So whether or not you had an NNRTI resistance, K103N was present, nucleoside resistance was present, TAMs were present or not, and revertant mutations and the like, each pair of lines shows essentially the same numbers, suggesting that in these patients who were receiving either a rilpivirine-based regimen, and if we're looking at the NNRTI mutations, or elvitegravir-based regimens, or in the control arms were receiving boosted PIs, that there was really no impact of these transmitted resistance mutations. And in the recently presented data from TASP looking at the pre-treatment resistance, this was a somewhat surprising result because it contradicted the data that we had generated earlier. You can see, first of all, there was a substantial prevalence of resistance, however, and this resistance was, again, mostly driven for NNRTIs by K103N. But there didn't seem to be any impact of that resistance on treatment outcome. And one of the unanswered questions about this analysis is whether the fact that tenofovir was being used in the regimen as opposed to AZT, which was used in the regimen that, from the study that I presented earlier, made the critical difference in this outcome. And I'll just show one slide of the impact of resistance in second-line therapy, because Nick is going to focus mostly on that in his talk. But in the ACTG study of second-line treatment, the SELECT study, where patients received boosted lopinavir, and were randomized either to do so in combination with nucleoside backbone or with raltegravir, what we found was that, first of all, there was no difference in outcome between the two arms, but somewhat surprisingly, but now consistently, those who had evidence of nucleoside resistance actually fared somewhat better than those who did not, the interpretation being that those who developed resistance on their first regimen probably were taking at least some of their medication, and those who failed without resistance were probably taking little, if any, of their medication, and once non-adherent, always non-adherent. And so in the second-line studies, they did poorly again. And Nick will have much more to say about that. But this leaves a critical question that remains to be addressed, because in second-line, EARNEST, and SELECT, where each of the studies showed persistent activity of the nukes despite resistance, few participants carried a K65R, and the success of second-line regimens was based largely on the use of a boosted PI regimen. We don't know yet whether an integrase strand transfer inhibitor, such as dolutegravir or potentially bictegravir, can take the place of a boosted PI in second-line regimens when there is pre-existing nucleoside resistance. That is a question that remains to be addressed. Now, even though I've painted a relatively optimistic picture, I do think there is some cause for concern about whether our current regimens are going to be completely robust against resistance, and these concerns come from what might be considered the inappropriate use of integrase inhibitors as monotherapy in this retrospective analysis from several different cohorts where participants or patients were switched to monotherapy for a variety of reasons, but not as part of a formal clinical trial. And then what happened was that quite a few of them had virological failure with resistance. Some of the resistance are reflecting surprising mutations like the 155H mutation or the 148 and 155 mutations that you wouldn't expect dolutegravir to select for. And so that raises the question of if you have a compromised nucleoside backbone, although we know from Viking dolutegravir seemed to do quite well in that relatively small study, if patients are persistently exposed to dolutegravir without other drugs in the regimen to support it, will we over time potentially see resistance, especially in a setting where monitoring may not be as frequent and intensive. So where does this leave us? Contemporary regimens are less likely to result in virologic failure and therefore less likely to select for drug resistance. But this may be dependent on regular monitoring of plasma viremia. Transmitted drug resistance is decreasing in many countries, but increasing in resource-limited settings. Transmitted nucleoside resistance appears to have minimal impact on response to protease inhibitor or INSTI-based antiretroviral therapy. And it may be time to re-examine the cost-effectiveness of baseline resistance testing in countries where it has become standard of care. So with that, let me end, and thank you for your attention, and I'll turn this back over to Jonathan.